Hello everyone, I'd like to create a short screencast to give you a quick orientation to the emergency room, focusing on workflow and the physician assistant role. Some of you have worked in emergency rooms before, and I realize that, and many of you haven't, so what I'd like to do is go through this quick orientation to talk about the different parts of an emergency room and how it all fits together. So, as you can see, I've drawn this amazing sketch, and of course, you immediately recognize it as an emergency room. Excuse my artwork, but I'll explain as we go along, and hopefully it'll make sense. So first we have the waiting room, triage, fast track, radiology, the CT scan room, which is basically the same department with radiology, but I separated it because it has its own role, main ER, and the ambulance bay. So here we have the overall view of the ER, and so let's dive into each individual section to see how they function. So first we'll start in the waiting room. So obviously this is where most people walk in. People arrive in the emergency room either by the ambulance bay or they just simply walk in on their own. The recent increase to try to improve waiting room times, and they'll talk about a door-to-dock time. And what that means is when the person checks in at the front and they register, the clock starts, and then they have the dock time is when the doc logs into that patient and on the computer system and then starts to track that. And the computer system will timestamp those times and keep track of what's called door-to-dock time. And an efficient ER is supposed to have a short door-to-dock time. And there's different ways to do that. One of the ways that they manage patients in the ER is they create a system of triage. And basically what that means is somebody from the emergency room, usually in a traditional setting, you'll have a nurse that will meet with the patient, figure out what their chief complaint is, figure out how well they're doing, and then they assign a level of acuity. And that can be from level 1, depending on the system you're using, down to level 5, which would be low acuity. And that acuity reflects urgency. So the more, obviously if somebody's coming in with chest pain, that's going to be something that's going to be quicker. If somebody's coming in because they have a cold for a week, then maybe something that's a little less acuity, so something that could wait a little bit longer. And obviously, emergency rooms are not managed by a first-come, first-served basis. That wouldn't make any sense, obviously. It's based solely on urgency. But you do want to try to move people through quickly to be efficient. And one way that's been developed is a system called RME. RME stands for Rapid Medical Evaluation, and basically what that means is a provider, instead of a nurse, the provider will meet the patient in triage, and the person will come out of the waiting room, go into triage, and they'll be evaluated, and the provider can start adding, or I should say ordering tests. Say the person needs a chest x-ray, the person needs labs, or the person needs a pain medication or something like that. That can be given during this process. And so instead of a nurse who really can't write orders, you have the person see a provider first, and that's supposed to speed up efficiency. And a lot of times they'll pull the person out of triage, put him, or I should say pull him out of the waiting room, and they meet with that provider. Those labs are ordered, then the person is put back into the waiting room. And sometimes patients' entire visits will actually occur only in the waiting room. They never actually make it to the main ER. And for someone with low acuity, that does help. Obviously, you worry about privacy and HIPAA, and ERs are obligated to try to do their best to protect somebody's privacy. But often it's difficult when you have a chaotic scene that happens in ERs at sometimes. And sometimes beds are separated by just a curtain. The ambulance bay. So physician assistant roles will vary based on setting. Some ERs will have the PAs rolling through the main ER, and they can actually accept ambulance patients. The emergency room that I worked at did, and you could get lower acuity patients, maybe somebody with a fall or something, and they would allow the PAs to do ambulance work. Other facilities maybe not. So if you want to work in an emergency room and you want that high acuity stuff, you might have to ask them about that as part of your interview process. And of course, you're going to want to have low threshold for seeking physician input with those higher acuity cases that are coming through the ambulance bay. Let's move to fast track. Now, again, I said that some emergency rooms, the facility will allow the PA to work in the ambulance bay or to take those main ER patients. A lot of times the PAs get relegated to just fast tracked, and so your role in the emergency room is your easier stuff, your lower acuity stuff typically. You need to be able to recognize people that have a serious condition that were sent to fast track potentially that maybe shouldn't have, so you have to be aware of that. But a lot of times you're going to get your less acuity patients, non-displaced fractures, potentially a lot of suturing, actually be a lot of suturing, and minor illnesses, fevers, coughs, things like that, things that don't necessarily need a bed and don't need to be there very long. So now we can move to the radiology department. Depending on the facility, some ERs will have their own dedicated radiology department, some may not. And again, when you do the RME process I was talking about before, one of the things that the techs can do is take the person from the waiting room, bring them to radiology, and then put them back in the waiting room. These can also be a significant source of delay. When you're ordering a test, when you're ordering a CT or something like that, the time it takes for that test to be done should be considered in the treatment that you're giving. And again, oftentimes with emergency room care, you're actually starting to treat somebody before you really know what the source of the problem is. So you got to take that into consideration, that could be a delay. And then work closely with your radiology staff. They'll help you out with how to order things. All right, so let's move on to the CT scanner. Some emergency rooms have a dedicated CT scanner. Many do not, so they basically share it with the hospital. So this can become a source of delay. If you wanted to order a CT, you have to think about the time it would take to do that. And that should play into how you're ordering your tests. Stroke receiving centers have to have a CT scanner available. And as that's important to be able to manage people really quickly. Let's move on to the main ER. This is where a lot of the action happens. These are your higher acuity patients, but not always. Some places don't really have a fast track. So you might see a blend of patients, and the PA's roles can vary based on the facility. Again, some are in fast track, some are in the main ER, depending on how the setup works. So you'll definitely want to be able to have those questions answered when you start your rotations. But in addition to, if you want to work in an ER, ask about that during your job interview process. Usually people in the main ER, again, are higher acuity. They're typically needing IV medications, likely admission. They might need more extensive testing. And because of those interventions, they put them there in the ER. So ultimately, patient outcome is determined by all the members of this team. They have nurses in triage, which play a vital role. The fast track people can be able to keep people moving in and out of the ER quickly, which frees up space and frees up time. And then radiology techs that can be very efficient are very, very helpful as well. So I hope that provided you with an overview of the emergency room and how it works. And hopefully as you finish the ER course and then you go into your rotations, you'll be excited to go into the emergency room and be able to create good stories and be able to help some people out. And I hope that helped benefit you, and we'll talk more about this during our course learning unit. Thanks.